Well, I think that there are really three challenges that we have. The first is that at the current doses we give, we're not getting the clonal regressions or molecular remissions that we'd like to see. The second is the drugs have some on-target and potentially off-target toxicities. And the third is that this isn't the only idea or approach. And I think all of those things lead to the concept that we need to try new targets alone and in combination with JAK inhibitors to see if we can push the envelope out even further. Well, I think the data, at least preclinically, suggests that we should be following spleen size to see if we see a further reduction in splenomegaly. But what we're hoping to see, obviously, is some evidence of disease modification, either based on allele burden or more likely just bone marrow fibrosis. We know from the EHA data presented that the improvements in fibrosis with JAK inhibitors can occur, but they take a long time, and they only occur in a subset of patients. So I think we're hoping that this preclinical data will translate to a more rapid, more consistent improvement in fibrosis. I think that reflects the clinical trial landscape. It's largely based on myelofibrosis. I think PV and ET are much earlier phase disease where safety signals are a bigger concern. And I think in general we want us to make sure drugs are clean and safe before we move forward to PV and ET, particularly given the recent challenges with the Sanofi agent. I think that's only going to get higher, that we'll want to see even more of a safety signal with myelofibrosis before going earlier in disease, although I agree with you that we do want to go earlier in disease because the drugs actually might be better in PV and ET than when patients have progressed to overt myelofibrosis.
Okay, so probably a few years from now we'll start kind of seeing the shift.
I hope we'll see it as early as next year, but we'll see.